Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone, and welcome back to another episode on the Health Trip Podcast. In 2015, I discovered that my cholesterol levels were increasing. My APOB was in the high-risk level. I was pre-diabetic. I carried the APOE4 allele, which is a risk factor for Alzheimer's disease, and I was a hyperabsorber of cholesterol. That means that my body was absorbing too much cholesterol. I was in perimenopause at that time. Each year, my cholesterol increased until in 2020, my numbers all doubled. I was post-menopausal at that point. In 2022, I discovered that I was also a hypersynthesizer of cholesterol, meaning that my body now made too much cholesterol. I could not catch a break. What was going on? I was the poster child for living a healthy lifestyle for the last 40 years. If what I just said makes no sense to you and you feel confused, do not turn off this episode. Stay with me. I am determined to help midlife women navigate menopause with science-backed resources and trusted authorities. Today, it's all about screening and solutions for the prevention of heart disease in women, which is still the #1 killer. I have invited a very special guest to the show, and I am honored to share him with you. I have been a huge fan of his for a few years now. While my episodes usually run for an hour, this may go over just a little bit, so pace yourself. You may even have to listen to it 2 or 3 times. I'm hopeful that I can bring him back for future episodes. Dr. Thomas Dayspring is a fellow of both the American College of Physicians and the National Lipid Association and is certified in internal medicine and clinical lipidology. After practicing in New Jersey for 37 years, in 2012, he moved to Virginia and served as an educational director for a nonprofit cardiovascular foundation, and until mid-2019 as a chief academic advisor for 2 major CV laboratories. Since then, he has served as a virtual cardiovascular lipidology educator. Career-wise, he's given over 4,000 domestic in all 50 states and several international lectures, including over 600 CME programs on atherosclerosis, lipids, lipoproteins, and their treatment, vascular biology, biomarker testing, and women's cardiovascular issues. He's authored several manuscripts and lipid textbook chapters and performed several podcasts. For several years, he was an associate editor of the Journal of Clinical Lipidology. He was also the recipient of the 2011 National Lipid Association's President's Award for Services to Clinical Lipidology and the 2023 Foundation of NLA Clinician Educator Award. He has over 40,000 followers on his educational Twitter X feed at Dr. Lipid, and he has Gold Heart member status as a professional member of the American Heart Association and serves as a social media ambassador for the European Atherosclerosis Society and the National Lipid Association. He is the leading global voice on lipids, and we are in exceptional hands today for the truth, the whole truth, and nothing but the truth when it comes to women's cardiovascular disease risk. The landscape for midlife women on social media, in our doctor's offices, and in the news is overwhelming, conflicting, and fear-mongering. Today, you will walk away understanding how to better advocate for yourself when it comes to assessing your risk of heart disease. A short medical disclaimer. By listening to this podcast, you agree not to use this podcast as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Consult your own physician for any medical issues that you may be having. And this entire disclaimer also applies to any of my guests on my podcast. So sit back, open your mind. It might take a little bit longer, so be patient, and let's enjoy the show. Hi, Tom, and welcome to the Health Trip Podcast. I'm so grateful to have you here and excited to share you with my community of midlife women.
Well, I really thank you for inviting me, Jill. I've known of your work for a little bit, and I think we can get our minds together and provide some great information for a very special group of people, women.
Absolutely. And I am one of those women trying to navigate my health journey, very similarly to the women who are listening to this podcast. My goal for today is to really help midlife women understand their right to investigate their risk for heart disease. And as you know, that is not an easy task in today's healthcare system. To start with, most women don't even know what to ask for and in terms of their screening. And then second, their requests are often turned down by their physicians. And I'm hopeful that after our conversation today, they will have a plan to execute and also understand treatment options. And since we're speaking to the midlife women, I thought a good place to start before we dive into screening is just to talk about the association between the menopause transition and that increased risk of heart disease in this population. So, what is going on and how is menopause impacting our risk of heart disease?
Well, menopause is a complicated transition, and of course, as a woman goes through those stages, it's not only her heart that one has to worry about; it's almost every other organ and part of her body. And of interest is when you, even if you zero in on the heart, you have to understand, are any of the therapies recommended? What are they doing to the other bodily parts in the woman? Or likewise, if somebody's just focused on the pelvis or the breasts or the bones, what are the therapies that might be suggested for them? What are they doing to heart disease? So, somebody who really wants to educate a woman about heart disease really has to understand a lot about midlife medicine in women. But with that being said, and with all of the things that can go wrong, it is not debatable that the number one global killer and cause of morbidity in women is atherosclerotic heart disease. So, although there are many issues to address, a woman really has to put heart disease almost at the top of her list as to, hey, do I have risk factors or risk markers that might portend cardiovascular risk for me? And if so, what can I do about them? And it's changed a lot, and we have newer modalities of diagnostic investigations nowadays that people should be aware about.
Yeah, but in terms of estrogen, because there, as you know, there are a lot of social media influencers who are also MDs. They might be an OBGYN, they might be a urologist, an internist, a general practitioner. And there are a lot of these people out there on the internet speaking to women to not take medications for heart disease and instead to really look at taking menopause therapy. And so we're going to dive into that. But what is going on with estrogen and its association with our heart? How is it protecting our heart? And then why in midlife is the decline in estrogen also increasing our risk?
Well, of course, that is the big hormonal change that occurs during the menopause transition. The ovaries just don't produce estrogen like they used to, and there are several consequences of that. For years, there's always a why do women get less heart disease until after menopause, and then they sort of catch up with men in the last 10 years. And certainly the development of estrogen deficiency would maybe put a bullseye on, geez, estrogen is important in what's going on or so. And it's been a long and complicated battle to figure that out. Look, I've been around a long time. I think I'm in my 53rd year of being an MD. And so for the probably the first couple decades of my practice, it was that, boy, if a woman is entering menopause, she must go on estrogen, preferably high dose. They weren't even worrying about progestogens in those days. It was just a woman needs estrogen, and that's going to keep her perpetually uh, healthy for everything. Of course, that did not work out. And it was only until the 1990s when clinical trials started to be done to really test that hypothesis or not. And we got a lot of answers that were not expected and everything. And as trials progress, you got to remember sometimes some of the early data coming out of trials looks, oh my God, terrible. And then as time goes on and the studies are analyzed with the thicker lenses and stuff, that some of the early conclusions that were broadcast, and sadly, media will jump on the absolute worst thing
Mm-hmm.
that anybody is going to say and broadcast it. So women were scared off of hormonal therapy big time because some of the early data suggested that at least estrogen replacement was adversarial to the cardiovascular system. And the first trial that came down was they enrolled women with very advanced coronary artery disease and randomized them to a hormonal therapy. And that shocked the world because it did not show estrogen in that group of women is protective. But of course, most women who we now understand should be given hormonal therapy, it's much earlier in life. You don't wait till a woman who's come in and had a bypass or a stent or an MI and start discussing estrogen with her. That's still a contraindication for that group of women. But what about the woman, as you talked about, the midlife woman who is starting to recognize some perimenopausal symptoms, or indeed she's gone a year without a menstrual period, so she is by definition menopausal. It turns out from subsequent analysis of the trials and other trials that have gone on that really estrogen is not adversarial to the heart at that time. It may even be protective. And there are other organ systems where the estrogen may be very protective at that stage of the game. Also, the bones being one,
Mm-hmm.
and the brain. It's now thought by those who are seriously invested in preventive cognitive impairment and even Alzheimer's disease in women that estrogen therapy is probably highly indicated in such a woman, presuming there's no contraindications in a woman to
Mm-hmm.
use hormonal therapy. So some of the early scare stuff has dissipated, and the newer stuff is very encouraging. What I've always said, and I'm a rare internist who a long time ago became extremely fluid with hormonal therapy, knew them all, was prescribing them. Most internists sort of run away from that. I
Yeah.
always joke the biggest fear for an internist is to get a call at night that, doctor, I have vaginal bleeding, because internists are taught nothing about that and they panic. Uh, and so they just don't study hormonal therapies or the various and numerous types of administration. So that, for the most part, might be the wrong person to get advice from. On the other hand, for the longest time, the gynecologists were the one, or you're a woman, you must be on estrogen. I don't care about anything else. And that's not true either. So it takes somebody who's really been trained in what is called menopausal medicine. My advice to any woman going through this time is try and find a practitioner competent in menopausal medicine. And a good place to start is the Menopause Society, because they
Mm.
actually certify people as menopause practitioners, and that's a person who's likely to understand some of the things I've just alluded to. A quick aside, I think I let you know one of my biggest bragging points is I was the first physician in the United States to be certified in both menopausal medicine and also lipidology. So it is an area I've spent a long time in or so, but it's complicated. So to me, estrogen or hormonal replacement therapy can be an incredible drug for the right woman, and it can be the wrong drug for another woman. So you truly have to understand the multiple things that would make you get into prescribing it. And it's really an evaluation of all the organ systems. Today, we'll spend mostly talking about the heart and what goes on.
Yeah.
Uh, I'll jump into that. So, as a woman loses estrogen, there are cardiovascular risk factors that do start to occur. That likely explains why, women are within the next decade going to catch up to the same cardiovascular risk that men have had, who, of course, never had the benefit of having estrogen through most of their lives. So, what happens as estrogen goes down? One of the biggest things, and not often recognized, is that estrogen is a great insulin sensitizer. And you want to have a body that's sensitive to insulin, because if you don't, you fall into the category of insulin resistance, which is like a mega risk factor for cardiometabolic disease, including prediabetes, diabetes, but all of the complications that go along with that pathology. So number one, you better keep an eye, if you're not going to use estrogen early on, keep an eye on the many biomarkers that may clue you in that, boy, this woman is becoming insulin resistant. And there are signals of that even long before the sugar will start to go up. But glucose elevation is like the last thing that occurs. And it's all, I don't want to say it's too late. It's never too late. But I would rather diagnose insulin resistance at a much earlier stage. So that's one. Blood pressure tends to escalate as estrogen dissipates. Estrogen is a very good endothelial type drug that keeps the endothelium of our arteries, that's the lining of an artery, very relaxed and able to contract and constrict appropriately. Without estrogen, you have vascular uh, I don't know, your vascular system, your arteries don't contract and dilate as efficiently as they should, and that will contribute to arterial wall pathology. And of course, what happens is also that the other mega risk factors for atherosclerosis, the lipids and lipoproteins in our system, start heading south, meaning they're not as good and desirable as likely they were before. Now, listen, and that's what happens at the menopause transition, but just a word for all women listening to this. Most of the lipid abnormalities start to occur long before the menopause occurs. So if you at a much earlier stage in life have identifiable lipid or lipoprotein abnormalities, you don't wait to menopause to treat them. You get consultation with somebody who knows, aha, in you, does this require treatment or does it not? But certainly at menopause, if a woman has not paid particular attention to some of those cardiovascular risk factors, it's an incredible opportune time to go in, get the proper biomarker testing that would give us insight to some of those things I mentioned, and then go from there. And it will be shocking to many women how many, remember, these are all silent quote unquote killers. They're
Yeah.
leading to the number one global cause of death and
Hmm.
disability in women, but they're totally asymptomatic. If you don't go checking for them with various diagnostic modalities, you will never know you have them. And you better know you have them because uh, as my friend Peter Attia has said, atherosclerosis should be an orphan disease. If we were all getting properly evaluated and then use the appropriate treatment for a person's given degree of risk, atherosclerosis would be wiped out as a disease. Sadly, that is only happening in an extremely small fraction of people, and maybe even smaller fraction of women who sort of think, oh, I'm protected against heart disease. The last thing I would mention is there is a inherited cardiovascular risk factor that is present in 1 out of 5 people globally. So that's like, oh, 1 in a million has this. No, 1 out of 5, that's 20% of humans, have inherited the ability to construct a lipoprotein called lipoprotein little a, abbreviation LP, parenthesis, small case a. When I say little a, I don't mean capital A, I mean a small case a. That's what that stands for. And it is a horrific cardiovascular risk factor. And if you test positive for that, couple of things. One, you need to seek out expert care as to what you should do to mitigate the risk. But since it is codominant inheritance, just like your blood type, one gene from mom, one gene from dad. That means 50% of your children may well have this LP little a that you passed on to them. Brothers and sisters should be advised to go get tested, and anybody who turns positive. So that's another crucial part of the workup a woman has to consider. The last thing I'll say in this part of our introduction is as a woman starts to gather these other risk factors, and we'll throw in family history and a lot of things that might or might not have occurred in pregnancy add to a risk. But at a certain point, if the risks look, oh my goodness, these are not good, certain types of imaging can really help ascertain a person's risk also. And these are non-invasive imaging. I'm not
Right.
talking about going to get a heart catheterization, but a non-invasive radiological or ultrasound evaluations of the blood vessels.
Yeah. All such amazing insights, and we're going to dig a little deeper into a lot of those biomarkers. In preparation for this podcast, Tom, what I did was I went back 10 years to 2015, and I brought up all my past blood work from Boston Heart Diagnostics. So I want to dig into all of these biomarkers that you and I know are really important, but a lot of the healthcare system do not find important. And so it's hard for women to go in and advocate for themselves when they're coming up against a wall. But I went back to 2015 and I mapped out my perimenopause, menopause, and I'm postmenopausal now at almost 57. And I mapped out my lipids, my lipid profile, and my genetic profile. And when I learned all of this information, and of course, I'm on some medications, and we're going to talk about solutions as well towards the end of this podcast. But it was really incredible for me to lay this out on the floor and start connecting the dots of my perimenopause journey, watching my lipid profile change for the worse, getting into menopause, and having my numbers double, absolutely double. At one point, my total cholesterol was over 320. And when I took action and how that all came down. So it's, I am not a unicorn in this space. I
Mhm.
have I work with midlife women on their health journeys. And one of the things that I do is I require them to go see a preventive cardiologist. And you and I both know who in Chicago would be the man to see, right? And they're not going to get that level of comprehensive data from their GP, their internist, or their OBGYN. And even if they did, that person probably isn't equipped well enough to decipher and help navigate this with that woman.
Two things. One, who watching this podcast would think that Jill is a 57-year-old woman? So whatever Jill is doing, let's just let her talk and I'll shut up
Oh,
because I
thank
think
you.
she's covered the answers. But Jill has obviously taken very good care of her multiple risk factors over time through a variety of modalities. The last thing I'll say without naming any names is the practitioner she's alluded to. I told you I was the first physician in America who jumped on the menopause lipid bandwagon. But my mentor was this particular physician. And I think I'm a little older than him, even, but
Mhm.
he had done many of the early studies with what various estrogenic and progestational compounds do to lipids and lipoproteins. And he just fascinated me. So we became very good colleagues and friends and have remained that way for way too long to go back. But he's an incredible resource. But so you never know.
Absolutely. One of the things I talk about often on my podcast and on social media is for women to build a healthcare team. And it doesn't just mean your OBGYN and an internist. It could mean a whole host of other team members and members. And one of those team members, in my opinion, should be a preventive cardiologist. And they're not easy to find. And I just recorded another episode with Dr. Martha Gulati, who you know, and we talked about how to find a preventive cardiologist. So I do think that, during this midlife phase of life, it is really important to really consider bringing on board more specialists. And I understand that we're not going to find a one-stop shop where we can get it all done, like you alluded to in a few moments ago. It's just not going to happen. But what we can do is start to build in these specialists that we're only going to have to see, maybe once, maybe twice a year, but once a year. And it's just so worth going the extra mile to put this person on your team.
Yeah, and I'll just also give a shout out. You don't necessarily need a preventive cardiologist. You need a preventive atherosclerotic doctor, and many of them are just lipidologists who are internists or even other specialties in medicine who have taken the time to study and get certified in atherosclerotic disease or lipidology or so. But again, they're not on every corner, so it does take some searching. And perhaps my greatest piece of advice for a woman is be careful going to Dr. Google and ask who to
Yeah.
see, but go to the various societies or say, like the Menopause Society or
Mhm.
like the National Lipid
Yep.
Association, and seek out proper care. like in virtually any other disease one can come down with or have risk factors for, you have to be your own advocate in today's world. And
Yeah.
don't take everything any physician tells you as gospel. That's it. That's the truth. Never be afraid to seek a second opinion. If you have done your own homework and you have a decent understanding of this, and your physician refuses to work with you or discuss that, pick another physician for, or certainly get a second opinion.
Absolutely. Well, so let's circle back to blood work, since that's something that is done in all doctors' offices and all women, hopefully all women are going in at least once a year. How important is getting an advanced lipid panel versus a standard lipid panel for menopausal women?
Well, this could devolve into an incredibly complex lipidology talk. And those who follow me on X, over 40,000 followers, LinkedIn for medical professionals, I am certainly well known as one of the top global influencers on lipid because of my teachings over the last 40 years in my educational venues. Is, to be honest with you, the only thing you need in the lipid lipoprotein world is a serum triglyceride level and a test called apolipoprotein B. That LP little a test I mentioned, since it's genetic, it's once in your life. It never has to
Right.
be repeated. You either have it or you don't. But the tests that have to be repeated are triglycerides and apolipoprotein B. Now, most people have probably never heard of that. So until I teach you what it is, let me just tell you it's a more modern, way more accurate version of the metrics you're used to getting, which would be the cholesterol metrics in the lipid profile. Total cholesterol superseded by LDL cholesterol. HDL cholesterol has fallen drastically out of favor as telling you much about anything other than generalized beliefs or so. So if you until you learn what ApoB is, and it's widely available in every laboratory in America, it's not an expensive test. Uh, you'd pay particular attention to that laboratory metric called low density lipoprotein, LDL cholesterol, which is basically the laboratory's way of taking out these particles that carry cholesterol called low density lipoproteins and weighing all of the cholesterol they are carrying in a third of an ounce in your blood. And as that LDL cholesterol metric goes up, 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 you really have too many of those particles carrying the cholesterol. And it's particle number that makes the cholesterol carrying particles leave plasma, enter your artery wall, dump the cholesterol, which is the cause of atherosclerosis, cholesterol in the artery wall. So LDL cholesterol is a decent estimate of, do you have too many LDL particles? The most accurate way, and here's the simple thing, that LDL particle that's full of thousands of cholesterol molecules, it is enwrapped by a single protein that makes it soluble in our plasma, and that protein is called apolipoprotein B, or ApoB for short. There's one ApoB protein on the surface of every LDL particle. So if we would measure ApoB, we are actually counting the number of ApoB LDL particles that exist, and again, a third of an ounce of your blood. And once that number exceeds a certain threshold, the odds are good. They are leaving plasma and crashing your artery wall. Now, look, they don't kill you overnight. This takes decades for them to keep crashing your artery wall and deposit enough cholesterol molecules that, oh my God, you now have injurious plaque in your arteries. But the sooner in life that we recognize that ApoB is high, and if you're not doing ApoB, that would be a high LDL cholesterol count, the sooner we can start taking therapeutic measures to restore that LDL particle concentration to a safe range. And that's basically what you have to know. Triglycerides are two reasons why I say you have to do them too. If elevated, they often correlate with high ApoB also. But there are two levels of triglycerides. Does a person have an astronomical level above 500 milligrams per deciliter, or does a person have a level between 100 and 500? That lower level of triglycerides is almost a sure sign that that person has the insulin resistance I talked about. When it's above 500, you may have insulin resistance, but you got other genetic issues going on. And your real risk is really more acute pancreatitis, inflammation and destruction of your pancreas, not so much the heart. So I want to know day one, are you one of those nightmare triglycerides? Because the therapy is very different that you would instruct that type of patient to somebody who has a trigs 100, 200, 130. So that's why triglycerides. ApoB, if you have it, you don't need LDL cholesterol. Let me just end with one other metric, which is in the lipid profile. Should be reported. Most labs do, but if they do not, it's a free calculation. If one looks at their total cholesterol level, that would be the cholesterol that's in all your lipoproteins. There are other particles other than LDLs. There's VLDLs and, of course, the
Hmm.
HDLs. Total cholesterol is the cholesterol carried by all the dump trucks in a third of an ounce in your blood. Because most of the cholesterol is in the ApoB dump trucks, a high total cholesterol should be a warning sign to somebody that they probably have a high ApoB level or so. But if I now HDL cholesterol, again, we're not going to devolve into this. It could be a 2-hour lecture, but HDL cholesterol is simply the amount of cholesterol carried by all the HDL particles that exist in a third of an ounce of your blood. For decades, please, nobody ever used the totally erroneous term. It was called good cholesterol. For
Hmm.
the simple reason that HDLs are not the particle that crashes your artery wall and dumps cholesterol. Those are the LDL particles, the ApoB particles. So if I took total cholesterol, the cholesterol in everything, and I subtracted from it the cholesterol that technically is not going to hurt you, HDL cholesterol, what would I come up with? Well, if I take HDL cholesterol out, the all of that cholesterol has to be in the ApoB particles, 95% of which are LDLs. So the cholesterol that is not in an HDL is simply called non-HDL
Hmm.
cholesterol. In essence, it's ApoB cholesterol. So it is actually a better predictor, a better correlate of ApoB than is LDL cholesterol. So, ladies, simple take your total cholesterol measurement, subtract from it your HDL cholesterol, and if that level is high, the odds are good when you get around to ordering an ApoB test that it is also going to be good. The reason why ApoB is preferred because you sometimes can have good-looking non-HDL and LDL cholesterol and still have an ugly ApoB. But again, that's a lecture for another day. So
Yeah.
my preference is just do ApoB. You're never wrong. But if you can't get ApoB for whatever reason, just calculate your non-HDL cholesterol and go from there.
What is that optimal number if you take your total cholesterol and you deduct the HDL?
All our optimal levels, two things. One, before you get heart disease, if you had this from your day of birth and get there, you wouldn't get heart disease. But once you have a high non-HDL or LDLC, to what level should you lower it? And that depends how risky you are. So if you come in and you've had 2 stents and your non-HDL cholesterol is high, I'm going to blow it away to basically a pediatric level. But earlier in life, I probably don't have to treat it and make it that drastically. But in general, so if we're talking early in life, where do you not want your non-HDL cholesterol to go above? It's probably about 100 milligrams per deciliter. Guidelines may tell you 130 or even higher. Forget that. It's a you if you go through life with a non-HDL cholesterol under 100 and you don't have that LP little a or some other bizarre genetic thing, you're going to be at low risk for developing plaque. The LDLC goal, if you're not looking at non-HDLC or a desirable LDLC, would be 70 milligrams per deciliter or lower. But again, if you came to me and you already were at risk, I'm probably going to even want a lower non-HDL cholesterol or a lower LDL cholesterol if I ascertain you're at high risk.
Okay, interesting. I like the way you broke that down because if some people don't have access or their physician is unwilling to do an advanced lipid panel and add in that ApoB, because I've been looking at a lot of blood work from my clients just to glance at it. There's never the ApoB. I mean,
I
hundreds.
know.
There's never the ApoB. It's always the standard lipid profile, but you've shared that there is a way to use those numbers and do a calculation and assess if you need further investigation or not.
Yes, so if you do that simple calculation,
Yep.
total cholesterol minus HDL cholesterol, and it's above 100, or if you know, boy, I already have some heart
Hmm.
disease or LP
Family
little a,
history.
you bring that to your doctor and say, look, I've done my non-HDL cholesterol. And if that doctor tells you nobody uses that or that's silly, run out of that office as fast as your sneakers will carry you, because that is an incompetent physician who is not up to par on ascertaining cardiovascular risk and certainly wouldn't be one to know how to treat it.
Yeah. I want to talk about another test that is not a standard test, but I know that it is something that you are very passionate about. And I'm actually very passionate about it too. It's the cholesterol balance test that Boston Heart Diagnostics runs. I've been having this run since in 2015. I was very fortunate to run into a functional medicine MD in the Chicago area over 10 years ago who was really ahead of her game in terms of where we live and what people were looking at. And I found out that I was a hyper absorber. Later in life, I found out I was a hyposynthesizer. And I would love for you to share your expertise on this and why this test can be really helpful in terms of assessing one's risk.
Oh boy, this is going to get me going now. This I could discuss till the cows come home tonight from pasture, but and I've written two comprehensive chapters in top lipid therapeutic textbooks on this particular topic. So, if you have high cholesterol in the blood, uh, as I sort of mentioned, your ApoB is probably high.
Right.
But if, whatever, your LDL, non-HDL cholesterol or ApoB is high, why? So you have to try and figure out why, because if you knew what's driving the pathology, perhaps there's a specific therapy that might work better in your case than in somebody else's case. So anybody with high cholesterol, the first two questions to ask is, are the cells in my body oversynthesizing or producing too much cholesterol, which would certainly usually drive up the amount of cholesterol floating in the particles in your bloodstream? Or is my intestine not behaving itself and it's overabsorbing cholesterol that's in my intestine? So, overabsorption, called hyperabsorption, or oversynthesis, called hypersynthesis, would both be common causes of why an ApoB level is high. Again, if you probably picked the wrong parents, you might be both a hyperabsorber and a hypersynthesizer. The good news is people who did pick the right parents and have genetic hypoabsorption of cholesterol have drastically reduced incidences for heart disease because basically their LDL cholesterol is much lower as since the day they're born and as they age. So it is important to try and understand those physiologic processes if you can. But obviously, you can't measure cholesterol because if it's high, did you overabsorb it? Did you oversynthesize it? So if you do come back where the cholesterol metrics are high or your ApoB is high, what are the blood tests that you can have a laboratory run to answer the questions? Jill mentioned of the test done by the Boston Heart Lab called the cholesterol balance test. Sort of a goofy name, but you're coming up with these cool names, and at the end of the day, you're going to get the numbers you need it. For those who go to physicians who don't have associations with Boston Heart Lab, and it might be hard to find someone, a LabCorp, the test would be called plasma sterol levels. So that's all your doctor has to write if he's associated with LabCorp, plasma sterols. Now, these are complicated tests. Boston Heart Lab is a very sophisticated biomarker laboratory, and they can run it with great accuracy. Fortunately, LabCorp knows they can't, so they ship out the blood to the Mayo Clinic, which is obviously a very advanced biomarker laboratory, and they analyze the sterols and they send the results back to the doctor through LabCorp. So we're getting into a subsection of lipidology called sterology. Don't let it intimidate you, because let's go back to the word cholesterol, cholesterol. cholesterol, you don't really pronounce the sterol, we call it cholesterol, but is one of numerous sterols that can exist in the human body. So if we measure them, we can get a lot of other cool information. So cholesterol is synthesized by the cells in the body. It's very complicated. It's 37 distinct steps, very complicated. What a biochemistry lecture that would be. But you don't have to know that, because here's what in the 37 steps, all you really have to know is step 36 to 37. That's called the penultimate step of cholesterol synthesis. So if we knew what were the two sterols that in one additional enzymatic step become cholesterol, and we measured either or both of them in the blood and they were high, we would know that person has to be oversynthesizing cholesterol. So those two biomarkers, there's two of them. One is called lathosterol, Lathosterol, not lathosterol. Lathosterol is the correct pronunciation. And the other pathway, it goes through a sterol called desmosterol, Desmosterol. And there's more nuances to it, but if either of those biomarkers are elevated, your cells are producing too much cholesterol. It gets cooler because we have two types of cells in our body that make cholesterol. Our brain, which is totally walled off from every other cell and the plasma in your body, and every other cell in your body, which is in every organ and skin, and you name it. Uh, the pathway used by the brain goes through desmosterol. So if I measure desmosterol and it's high or low, I know how much cholesterol your brain is making. Very important, because the brain only has one source of cholesterol, and that is synthesis. The brain cannot accept cholesterol from anything floating in your blood. By the way, an aside, so if somebody lowers your LDL cholesterol quite low, which likely will prevent heart disease, that has zero effect on the brain, because LDLs do not supply the brain with cholesterol. They can't cross the barrier between the blood and the brain, called the blood-brain barrier. The peripheral cells use a different pathway that goes through lathosterol. So if lathosterol is high, all the cells in your body, including your liver, are making too much darn cholesterol. Here's the bad side. If the liver cells are overproducing cholesterol, the liver knows at a certain point cholesterol becomes toxic. So the liver does not want to acquire any more cholesterol, which would cause a fatty liver. So the liver shuts down the mechanism by which the liver clears these ApoB cholesterol carrying particles from your plasma. By the way, that is done through something called an LDL receptor, which recognizes and grabs the LDL particles, pulls them into the liver where they are destroyed. Obviously, if they go into the liver, they can't crash your artery wall. So that clearance mechanism is very desirable, but you need LDL receptors to do it. If your liver has too much cholesterol because it's oversynthesizing it, the liver makes less LDL receptors. Uh-oh, you stop clearing your ApoB particles. Their elevation goes up, they go right into your artery wall. So again, over time, hypersynthesis of cholesterol is a mega risk factor because it raises ApoB. What is the other way your liver can acquire too much cholesterol? Because your intestine, which should be engineered to only accept the proper amount of cholesterol from whatever in your gut, when it gets to the intestinal cells that are called enterocytes, those enterocytes must have to make a decision, ship it back to the gut because too much was absorbed, or put it in an intestinal produced lipoprotein. It's an ApoB particle called a chylomicron, which delivers the absorbed cholesterol to the liver. So if you're absorbing too much cholesterol, in a matter of minutes, it's going to wind up in your liver. When the liver gets too much absorbed cholesterol, guess what it no longer does? Produce LDL receptors. So hyperabsorption of cholesterol is a second cause of high ApoB, high LDL cholesterol. If you have both hypersynthesis and hyperabsorption, you really are not clearing any LDL particles, very high risk. So once I ascertain hyperabsorption or hypersynthesis, and I've already told you how to diagnose hypersynthesis, I can pick a therapeutic modality if your ApoB is too high. And if you are over-synthesizing cholesterol, what is the therapies uh, apart from diet? And the best dietary measure to reduce synthesis is start restricting saturated fat, because saturated fat causes cholesterol synthesis and it makes the liver stop producing LDL receptors. So it's no wonder that so many who are saturated fat imbibers have high ApoB. All right, so you'd want to clean up your diet a little bit with that. Number two would be, are there pharmaceutical measures that inhibit synthesis of cholesterol, especially in the liver, which is the organ that makes most of these LDL receptors? Yes, there are two. And by far the most commonly prescribed, because they're cheap, basically free if you have any type of healthcare insurance, and totally generic, and even if you had to pay for them, they're pennies on
Mm-hmm.
the dollar,
Yep.
would be the statin class of drugs. There are 7 statins. They have different potencies, different dosages, so it takes an expert to perhaps pick which the best statin for a given person. But that is where if you restricted saturated fat and you still had a high ApoB, still had too much synthesis, you would pick a statin. I prefer to start with low dose statins and then go from there. Uh,
Wait,
there
Dr.
is a
Dayspring, I have a quick question. Once you discover the root cause of the high ApoB or the non-HDL or the LDL, and you discover that this person is either a hyposynthesizer, a hyperabsorber, or both, how long will you give that person to change their diet and lifestyle before you suggest a statin? Because there are people listening right now thinking, oh boy, but everyone out there on the internet is telling midlife women not to take a statin, that we should just go on HRT and we'll be fine. So how long do you give them to make that change?
Number one, trust the professional societies on what drug you need, not some internet denier. So that aside, uh, you do you go with lifestyle first? Do you give a drug day one? Do you do both? It all depends on your risk. So if you're early in the game and you don't have 5 other cardiovascular risk factors, you have not had a stent, a bypass, God forbid, a heart attack or a stroke, uh, day one, you might just analyze, and a good nutritionist can really look at somebody and do a dietary history and have a good idea on taking too much saturated fat or not, and if so, they can address it. If and there are other nuances in the lifestyle you might suggest to a lower synthesis. If that is a rather low risk person, you always go with the lifestyle, and you should give that almost 3 or 4 months to
Okay.
see what 2 reasons. Number one, because a lot of people are great for doing lifestyle for 3 weeks and then stopping
Right.
it. So everything
Very
looks
true.
good in week 2, but in week 6, you're right back where
Right.
you started
Is it
from.
sustainable?
So you should give a chance to see. Number two, if you have somebody who you're not comfortable, they're at moderate risk, and then you might want to start with a low dose cholesterol synthesis inhibitor along with the lifestyle and see. Remember, anytime you go on a drug, if results come back spectacular, you can always stop the drug and see what happens.
Right.
And of course, if you day one have a high risk person, they go on both lifestyle and pharmacological modulation of their synthesis. Just a quick aside, nobody's going to ever use it day one because it's super expensive and not usually covered by drug companies. There is a second cholesterol synthesis inhibitor called bempedoic acid,
Hmm.
right now reserved for people who are intolerant to statins or are in a really high risk category where the statin didn't get their ApoB to goal. I want to jump quickly to people like yourself who have ascertained I'm a hyperabsorber of cholesterol. So, how does Jill know that? Well, there are other sterols that she can check. We all eat veggies. Believe it or not, we animals use cholesterol in all of their cell membranes. Plants don't make cholesterol, with rare exception. So they use very similar sterols to make up their cell membranes, and they're called phytosterols, plant sterols. So evolution has told our intestine, don't absorb plant sterols because there's no use for them in the human body. At a high level, they can be injurious. So the intestine has been given certain mechanisms to restrict the absorption of phytosterols. So if I measure phytosterols in a patient like Jill, unless I find an incredibly trivial amount, there's always a few that leak in, I would know she's not an overabsorber of plant sterols. And if you don't overabsorb plant sterols, there's no way you're overabsorbing cholesterol. Vice versa, if I find a high level of plant sterols, phytosterols in Jill's blood, her intestinal absorption apparatus is broken. It's letting all the sterols in. And if she's letting phytosterols in, she's letting serious amounts of cholesterol in. So that's how we diagnose it. And obviously, I have to name those two sterols, which will come back on these tests that we measure.
Hmm.
And the two most common phytosterols that tend to get overabsorbed, one is called cytosterol. Cytosterol, it's really called
Hmm.
cytosterol, Sitosterol. And the other is called campesterol, Campestrol. So if I measure them in the blood and they are elevated, I know we have a hyperabsorb of cholesterol. Now, if that person has a high ApoB, I would not throw a statin at that person because the high ApoB is primarily due to too much absorption. So fortunately, we have a rather incredibly safe drug that's been around for 20 years that drastically reduces the intestine's ability to absorb cholesterol. It's called the ezetimibe. It's a generic drug. The brand name used to be Zetia. And obviously, most doctors would prescribe the generic version, and that significantly reduces. So if you stop absorbing cholesterol, your intestine stops delivering cholesterol to the liver. Your liver then upregulates more LDL receptors to get the cholesterol that it needs. The more LDL receptors, the lower your ApoB. And the odd person who has high synthesis markers, high absorption markers, you could go stepwise, flip a coin, go ezetimibe first, statin first, or vice versa. But again, if their risk is a little higher, we would use a low dose statin plus ezetimibe day
Yep.
one. Just like in blood pressure nowadays, we often start
Hmm.
two drugs rather than one for the
Yep.
higher levels. So that's pretty much the absorption story. There's another whole story, Jill, that maybe we can do another time on. Uh, the overwhelming majority of cholesterol that you're going to absorb from your gut did not come from your mouth. It came via the liver shooting cholesterol in the bile duct down into your intestine. And about 85% of the cholesterol that is available for absorption into the intestine comes from that route, not from what you ate. So, ingested cholesterol is a minor contributor to the amount of cholesterol that you can absorb. So this is why, unless you diagnose hyperabsorption, telling a person just to restrict cholesterol in their diet could be a futile waste of time if that person is not a
Right.
hyperabsorber of cholesterol. And the last caveat, because people are doing this, if I diagnose hyperabsorption of cholesterol in you, I let out a little sentence that if your phytosterol levels go really too high in the blood, they can be injurious because human cells don't want phytosterols. And that person diagnosed as hyperabsorption should never, ever, under any circumstances, supplement phytosterols, which are sold in all the health food stores as a way to lower your LDL cholesterol. Never if you're a hyperabsorber. So good to know your absorption status.
Absolutely. It's been an absolute game changer on my journey once I found out I was a hyperabsorber. And then why? My question is, are we born this way? Or is it in midlife that some of us can develop to be a hyper absorber or a hyper synthesizer?
Well, listen, the genes are basically behind everything, but whatever genotype you have, the genes interact with the environment. So whatever genes you inherited or didn't inherit, if you're going to, and the environment I'm talking about with lipids is your nutritional environment. If you're going to pig out, even if you have pretty good genes, you could cause some bad lipid lipoprotein stuff.
Hmm.
But if you've inherited any of these bad things and then you're pigging out, your lipoprotein phenotype will be far worse. So it's an interplay of lifestyle and genes or so. We can't change your genes right now. Thank God, if we identify these things, depending on your degree of risk, we have great pharmacological therapies. I didn't mention, because this is not going to be a 3-hour podcast today, there are certain nutritional quote unquote supplements that can also help reduce cholesterol absorption. I'll mention one: lactobacilli yogurts can help do
Hmm.
that. Plant stanols, which are very different than plant sterols, block sterol absorption, so they're another option. So there are other ways short of a prescription drug. Now, if you have serious hyperabsorption, serious ApoB, you need the prescription ezetimibe, but there are other ways to either help ezetimibe or forestall ezetimibe's use if you're a hyperabsorber.
What about taking red yeast rice versus a statin?
People are red yeast rice, and they talk, oh, it's yeast, it's a plant. I hate to tell them this. The first three statins that ever came on the market, lovastatin, pravastatin, and simvastatin, that was Mevacor, Pravachol, and Zocor, are all yeast derivatives. They're the same thing as red yeast rice, except they're a lot more potent. So you are using a statin, albeit a weak statin, if you choose red yeast rice. Its real problem is it's not an FDA regulated drug. So when you pick up your red yeast rice, not a prescription item, you have no idea what's in the tablet. You may actually be getting a tiny dose of the statin that's in there, or you may not. Could be a placebo. So if you really need to inhibit cholesterol synthesis, my preference is to use an FDA regulated statin at the smallest possible dose. And each statin has a different baby dose, so you should know about them. And there are other reasons to pick one statins over another too. This is why you need somebody well schooled in lipid modulating therapy.
And I just want to make clear that taking menopause therapy, taking estrogen, is not going to help lower your or change your status of being a hyperabsorber or a hyposynthesizer.
Right. Yes, but a little bit back to the estrogen, because we do know estrogen can lower ApoB a little bit, and in the analysis of all those trials done years ago show that in the perimenopausal, early menopausal worlds, perhaps modulating lipids with estrogen is not going to hurt you. It may even beneficially add
Hmm.
to it. Now, listen, estrogen has no FDA indication to treat lipid disorders or anything,
Right.
but believe it or not, and there is a class of incredibly potent lipid modulating drugs called PCSK9 inhibitors. And we usually save them for the nightmares of the world or the people who have had heart attacks, strokes, because it's our most potent ApoB lowering drug. But it's very expensive. You need your third party payer to sign off on them. So they're not everyday use drugs for most people. But there are three PCSK9 inhibitors on the market. And believe it or not, it's very, very weaker than the prescription, but estrogen is a PCSK9 inhibitor. And
Hmm.
that means estrogen can favorably affect your LDL receptors, which is its mechanism for lowering ApoB. So I just thought I'd toss that in as
Yeah,
some
no,
nice.
that's really interesting.
Yeah.
I mean, I'm one of those women who is on all of the hormones, and I take ezetimibe, and I also take a low dose statin at 5 milligrams a day. So I do all of it, but I have very, very poor family genetics. My doctor ran a genetic analysis report for me on my risk, and everything is like severe risk, severe risk, severe. He said, you have the worst genetic profile. So for me, I go back to, and this is what I work on with my clients from a health coach perspective, is what's your why? What is your why for making the decisions you're going to make? And for me, I have 5 kids. I'm going to have a big family, lots of grandkids, and I want to be around and keep up and stay in shape. And, um, I think it's really important to reconnect with your why when you're faced with having to make a decision on what to do about your increased risk during the
Yes.
midlife years.
And with respect to the hyperabsorption, there's another commonly tested gene that more and more people are getting nowadays, and it's called the ApoE genotype.
That was next on my list.
ApoE, the real reason to measure it, because there are three types of ApoE you can
Hmm.
inherit. And the type called ApoE4 is a risk factor for cognitive impairment and Alzheimer's disease. So you want to know about that early in life, because believe it or not, there are many measures early in life, and including midlife, the consideration of estrogen therapy to ward off cognitive impairment or so. But if you happen to test ApoE and you get that E4 that may be predisposing you to neurologic disease, there's a high incidence of hyperabsorption of cholesterol with ApoE4 also. I was
I have the ApoE4.
yeah. So if I haven't sent it to you, I was one of the co-authors on a paper that demonstrated this. In the lab I worked for, we did over 600,000 analyses of sterols and the hyperabsorpters. There were two groups of people that stood out as hyperabsorbers of cholesterol, ApoE4 carriers and menopausal women. So,
Hmm.
so I don't think we've worked it out yet, but somehow estrogen is tied in with the absorption of cholesterol too.
Very,
Maybe it's
very
true,
interesting.
who knows, but we just haven't figured that one out yet. We got the LDL receptor thing with PCSK9, estrogen's effect. So,
And because that's a genetic biomarker, it's just something you have to do again, like LP little a. It's once in a lifetime. You can have your kids, all five of my kids, I know I have a spreadsheet with all of their biomarkers, all of their genetic markers. So they all know, what what their profile is and how to manage it and who to work with. So I think it's really important that any woman listening to this podcast can also help support her family, all her adult children or her young children by getting tested early and just finding out the information.
Amen to that. No argument here.
Yeah.
The old days we had to wait for the heart attack, and hopefully you lived to as you got through the emergency room. Uh, but nowadays that is failure of therapy, either because the patient was silly enough never to go get a cardiovascular risk assessment, or they were not being treated anywhere near as aggressively as they should be. It should be an orphan disease, as I started off.
Yeah. I have a couple final questions about statins. There's, a lot of could be a lot of side effects, and some people feel them more than others. I'm very fortunate that I don't feel any of them. But one of them is a CoQ10 deficiency. And a lot of people don't want to take statins because they've heard that they might not even know what CoQ10 is, by the way, but they've heard there might be a deficiency in this enzyme and then also in mitochondrial function. And I just wanted you to speak on that because the fear that goes into women's minds from the internet of why not to take a statin definitely outweighs their decision to take the statin when it's not
Yeah.
fully understood.
Well, look, CoQ10 is a mitochondrial enzyme. And your mitochondria is a little organelle within every cell that
Hmm.
basically regulates energy balance in the cell and everything. So crucial, crucial little organelles in our system, and they need CoQ10 to work. So the people, and it's broadcasted all over, if you take a statin, you're going to lower your CoQ10. Well, basically, remember, CoQ10 has to be in the mitochondria to work. When you measure CoQ10 in the plasma, CoQ10 is a lipid. So where is it found in the plasma? It's a component within these lipoproteins that are carrying cholesterol. And by far, the most numerous particle that carries most of the CoQ10 are your LDL particles. So if you prescribe a statin, which are drastically lessening the amount of LDL particles in your plasma, of course, plasma CoQ10 is going to go down. Now, two things. One, nobody has ever shown that plasma CoQ10 has anything to do with mitochondrial CoQ10. So that is a question still needs answering. Uh, Two, if you think it does, the things they're ascribing to low CoQ10 is you're going to get muscle aches on the statin. So if you get muscle aches on a statin, many people supplement CoQ10 and to see if the muscle aches go. And that's been tested in several clinical trials. One, it seemed to help, and almost all the others, it was null. It did not a blessed thing. So I don't know that replacing CoQ10 is necessary. If, though, you're afraid that I'm lowering CoQ10 in the plasma, take CoQ10 with your statin. Many
Hmm.
doctors advise that. This way, if you ever test it in the blood again, it won't be low and you can have a peaceful night's sleep. That could be total bungus and you're wasting money. And CoQ10 is not a particularly cheap supplement.
Right,
And when it is recommended, the dose required seems to be quite high. It's not a baby dose. So if you're
right.
buying a baby dose, you're probably taking a placebo. So the story is still on that. I have never heard of a downside to taking CoQ10. So if somebody wants to spend their hard-earned dollars and take a CoQ10 supplement, I'm not adverse to that. Although if using clinical trials, I don't think there's a lot of evidence to support that. So that's the CoQ10 story.
Okay, good to know. I take CoQ10. Well, ubiquinol, same
Yeah,
thing,
there's
but
no
right.
reason so
Yeah,
that you
yeah,
shouldn't.
right. Yeah. So the final question I have in terms of screenings for women is about getting a CAC scan. And this reminds me of DEXA scans, right? Why wait till you're 65 to get a DEXA scan, which is measuring your bone mineral density when you're in midlife and you want to capture a baseline so you know what the story is of your bone health? It's the same thing with the CAC scan. Doctors don't want to give these prescribe orders for a woman to go get a CAC scan, even though you can actually walk in and go get a CAC scan at some hospitals here in Chicago. But can you just share what a CAC scan is, why it's useful or not useful in this journey? And if it is a really good score, is there anything else to be worried about?
Uh, well, again, a complex topic or so. Remember, the reason we're talking about cardiovascular risk factors is we don't want anyone to develop atherosclerotic plaque in their coronary arteries, cholesterol buildup. Now, that goes on for decades, but as cholesterol builds up, our immune system sends in white blood cells. Like if you had an infection in your artery wall, your white blood cells would go in and kill the bacteria. So if you are building up plaque in your artery wall, that plaque tends to get inflamed. So the immune system sends in the fire engines, the white blood cells, to put out the fire in that darn plaque. So the human body's defense against cholesterol plaques building until they explode and cause a clot is to wall it off with cement, like the Russians did with Chernobyl. There, you bury your mistake. So if the immune system sees a plaque, what the immune system doesn't want is for that plaque to get inflamed and rupture, because then the cholesterol induces a thrombus in your plasma. So they, by depositing calcium along the surface of the plaque, it makes the plaque what we call stable, far less likely to rupture and cause the thrombus that is ultimately what's going to kill you or cause big problems. So it's actually a part of the body's healing process to develop calcium in your artery wall. But here's an interesting part about that. Most people know calcium is radio opaque. You can see it on an x-ray. That's why if you see an x-ray, you see all your skeleton very easily because the bones full of
Hmm.
calcium stand
Right.
out. Well, if we do a specialized x-ray of your chest called an ultra-fast CT scan, there should never be any calcium along your heart because the arteries that supply blood to your heart muscle, it should not be calcified. If they do, you have atherosclerotic coronary heart disease. So by picking up coronary calcium, it establishes the diagnosis of coronary artery disease and immediately elevates you to the high risk category. And that's where that is day one. You go on both lifestyle and drugs if you have a positive coronary calcium score. There is a downside to that. Suppose I do that and it comes back zero. Well, there are X number of people with a coronary calcium of zero still get heart attacks and plaque ruptures or so. So it's not you're guaranteed not to have a coronary event, but your risk is much lower, that's for sure. So the downside to that is suppose I do an ApoB on you and it's really ugly, and I know you need lipid modulating drugs because you're at a genetic level that portends terrible risk. But now you get a coronary calcium and it's zero. You say, I'm not taking a drug. My arteries are clean. Well, they're clean today. What will they be in 3 years, 5 years, 10 years? And remember, today with longevity, if you're a midlife woman at 40 or 50, you could have another 40, 50 years to
Right.
live, but not if you're going to have a stroke or heart attack when you're 80, which is 2 to 3 decades from now. So you never want to ignore cardiovascular risk factors, regardless of what CAC. Now, the treatment perhaps could be a little less intensive if your coronary calcium is zero. It's not an emergency. You have time to get the ApoB because I did imply it takes a long time for atherosclerosis to build up. So coronary calcium is a great test. Like all tests, it has to be interpreted and used properly. The reason why it's not usually recommended to younger women is they go by the age-old thing. Well, women don't get heart attacks till after menopause. Well, if you've spoken to Dr. Galati or other experts on women's health, there are lots of premenopausal women who get coronary atherothrombotic events because they have these risk factors, insulin resistance, LP little a, you name it. And if they never were tested about them, they might not be seen. So, done at an earlier stage in life, you're more likely to get a coronary calcium of 0, even if you have horrific coronary risk factors that do require treatment. So as long as you're going to somebody who knows, who's not going to say coronary calcium is 0, get out of here, you never have to worry about your heart again. Or like all tests, they're all useful if you know how to use them.
I feel like I'm the poster child for this podcast episode because I do have a CAT scan of 0, and I am on ezetimibe, and I'm on the statin, like I mentioned, and I have terrible genetics. So,
Well,
you know,
listen, Jill, you mentioned we were going to say, if you want, I'm happy to come back another time and we could go through your metrics and give
oh, that
more
would be great.
education on this.
Yes.
I know you wanted to keep this to an hour today.
Yeah, yeah,
We've
yeah,
outlived our usefulness, but there is so
absolutely.
much more for me to
Yes.
instruct women. And my last joke of the day, what people used to, in my practice in New Jersey, was called the North Jersey Institute of Menopausal Lipidology. And doctors, and I've lectured in all 50 states, why the heck are you so interested in menopausal women? And I said, really, it's a good cause. I'm married to one. And I want to keep her around as long as
Yeah, for
possible.
sure. Oh, I love that. Yeah. Oh, well, Tom, thank you so much for your expertise, your generosity, and the way that you've been able to explain these very, very complex, nuanced bits and pieces of information for our heart health so that women can really better understand and be a better advocate for themselves. Because guess what? No one's coming for you. Right? We have to take care of ourselves and, do the work and advocate and stay on top of our health journey so that we are around for the next 30, 40 years. I'm always all about what are your 70s, 80s, and 90s going to be like? What's that vision for you?
And I know you, Jill, when you get to that stage, you're not going to be a hockey mom, but a hockey grandmom.
Totally. I will still be in the rinks.
Yeah.
Absolutely. Well, Tom, thank you so much again. I am grateful that you offered to come back because, I will take you up on that offer. So thank you.
Nah, love chatting with you. Take care.
Yeah. Thanks for tuning in, everyone. Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.